we have a jam-packed hour. And we already talked about this, but thanks so much to SPARK and ADAA for sponsoring today's talk. And just to give a little preview about what we're going to be talking about today, we're going to share some findings from a longitudinal study. We want to have a, short discussion on what do we know about mental health disparities in autistic individuals? How does depression itself look different across the lifespan for autistic individuals and how it may show up a little differently? What are the factors that are going to impact the experience when a person has both co-occurring autism and depression? And finally, we can talk about everything we know, but if we're not talking about better supports and increasing access, then we would be remiss. So we want to make sure we're touching on that. So you can see we have an ambitious agenda, but I believe we can get to it all. Just a couple of things for housekeeping. This today is educational content and in no way should be considered like a replacement for therapy or a kind of therapeutic support group. While we're going to be talking today about depression, we won't be speaking about suicide, but we also know people are suffering out in the world. So for any reason you are in crisis today, feeling unsafe or suicidal, please be sure to go to your local emergency room or call the suicide prevention hotline. And just as a reminder for the Q&A, the real idea is we want to feel like a community where it's safe and supportive for everyone. So I have full faith that that's the way the questions and like sort of comments are going to be, but just a helpful reminder to that as we get to that part of today. So why are we talking about this? Why did SPARK decide to sponsor this? Why did ADA decide to sponsor this? Why are all the talkers here today? And what we really want to share is this idea that autistic children and autistic adults have similar mental health problems as typical adults and typical children. What we know even more is they experience negative factors that can impact the mental health experience in a very specific way. But what's really, really important is autistic children and adults actually experience co-occurring mental health challenges, including depression, the focus of today, at even higher rates than typical adults. So what we know is there is a need, and hopefully these people are showing up to our office for services and for therapy, and better understanding might be what are the limitations to accessing that, but also for the professionals out there really knowing that you're likely going to have an individual who's autistic showing up in your office. And then I think the biggest thing we really want to drive home is we know autistic individuals can benefit from psychotherapy. You would never withhold penicillin from an autistic person who has strep throat. So why would we withhold top line treatments to individuals with depression just because they're autistic? It's just figuring out how does that treatment maybe look a little different given some of the things we're talking about today. So I'm going to mute myself and turn this over to Zheng so she can talk about some of the wonderful research that she's been doing.
Okay, thank you, Rebecca. As Rebecca mentioned, I'm going to share some findings from our recent SPARK longitudinal study on depression and depression services. So the motivation for the study, as Rebecca mentioned, we know that autistic adults are consistently reported to be at higher rate of experiencing depression. And I think one of the highest rate reported so far is 77%. So that's very alarming. And we also know from depression studies that poor mental health across all different populations would impact life functioning in adults. So including making it hard to be 100% for work or for their significant others. Besides, we also know the effectiveness from the research of the standard depression treatment for autistic adults are still pretty limited. And we know that insufficiently treated or untreated depression may lead to very dire consequences, such as hospitalization. And then it will be helpful if we can identify some novel treatment targets, like Rebecca mentioned, if we can modify some of the known treatment that can be better targeted towards the autistic individuals, that would help improve the effectiveness of treatments. So given that we know pretty little about how autistic adults are being treated in the community for depression, and that we don't know too much about how their life aspects or experiences are associated with their depression. We launched this longitudinal SPARK study. So we recruited 315 individuals from the SPARK Research Match Registry and launched our initial survey in March 2020. We all know that's right before the widespread of COVID-19 pandemic. So all the adults who are surveyed in our study provided information on what kind of services they're getting for their depression, and they all fill out the mental health measures on depression symptoms, anxiety symptoms, stress, and loneliness. And besides, they also reported about their life circumstances, such as employment, social experiences, and sleep. I also would like to mention that this project is done with my mentor, Dr. Summer Bishop at UCSF, and also Dr. Julie Taylor at Vanderbilt, and Dr. Ryan Evans at Cincinnati Children's. And we are very grateful to receive support from SPARK and also funding support from Autism Science Foundation Fund. So as we square all that away, I'm going to share some of the highlights from our study. So first of all, as we're interested in depression services, we asked adults about their depression symptoms and depression services. So first of all, about half of the autistic adults we surveyed, they scored high levels of depressive symptoms that raise clinical concerns. Among them, the majority, over 80% of them, have reported that they received a diagnosis of depression from a mental health provider. And the rest who have not received any diagnosis all mentioned they have concerns about their mental health and want to talk to a provider about their concerns. And we also find that depressed females with autism are more likely to get a diagnosis of depression than males with autism who are depressed, despite the similar base percentages of them reporting concerning levels of depression. So meaning that there might be possible sex biases in the screening and diagnostic tools that we use to diagnose depression in males. And then we also look at how many of them are getting treated for their depression. We see that only about half of the depressed adults are currently in active treatment for depression, and that people who have been diagnosed with depression and who have higher levels of education are more likely to be treated. So it is not surprising that given the insurance-based care system in the US, that the people who would need a diagnosis to get treated, right? And on the other hand, the higher levels of education lead to more resources, kind of indicate the service disparity even within the autistic population. And then we're interested in understanding more about what are the barriers holding them back from accessing treatments. So these are the top themes that identified as service barriers by our adults. Next, please. We see that the top one barrier identified is the financial and insurance issues. One of the participants in our study mentioned once they got unemployed and insurance rate went up, they could not afford to receive the needed treatment for long term. So they just decided to take the meds and struggle through it. And the second most mentioned barrier is about the accessibility of care and that a good fit of care. One participant mentioned that there are very limited number of providers in their area. And relatedly, the third common theme is about professionals' lack of understanding of depression in autism. That most therapy is designed for neuronormative people, and therapies lack the understanding and training to understand how to support individuals with autism who are also struggling with depression. So these barriers really highlight that we need better policymaking to support adults and improve access to care. Besides the barriers, we're also interested how helpful actually are the depression treatment that adults are getting from their perspective. So we asked about that. So among the two most commonly received treatment for depression, medication and individual therapy, most of adults actually perceive the treatment to be at least moderately helpful, and half of them think those treatments are very helpful. So I think this is very promising, and it's another point to really urge us to improve the access to the care that adults really need. So besides how helpful the treatments are, we also see that adults reported a very prolonged time of being in treatment. So for an average of 5 to 6 years. This could be an indication that the depression are pretty persistent in our autistic adults population. And it could also be that treatment, although perceived helpful, may not be as effective as they should be to really graduate adults with the level of functioning they like to be out of treatment. And this long time of treatment is really incompatible with insurance-based care system and could be unsustainable with growing needs and limited resources as identified by our adults already. So besides the treatment services, we're also interested to understand how the changes of depressive symptoms are over time. So given the COVID-19 pandemic with all the societal changes, we decided to follow up with our cohorts of adults. So we launched a survey again in May 2020, and we see that this sample of adults in May 2020, they actually reported a lower rate of depressive symptoms and anxiety and loneliness on average at a group level. However, when we actually look deeper, we found that those who started out with more depression and anxiety are more likely to experience the negative impact of COVID-related distress. And those who are more anxious from the beginning reported more difficulties coping with the change. And again, we follow up this year with this cohort in March and July 2021. We see that actually their levels of stress and loneliness increased this time in this year. And the anxiety and depression symptoms are back to the baseline when they surveyed in March. And we also observe a very large between individual variability, meaning that the individuals are different. They're experiencing these changes in society very differently, and they possibly would need different kind of support. So it also highlights the need to really tailor our treatment to support these adults. Next slide. And besides looking at the depressive symptoms over time, I think the other piece we really want to gain more knowledge on is what are the individual factors that matter for depression. So one of the things we're interested in is to gather information about how social experiences matter. So we know that social skills training is always, a lot of times, recommended for adults and adolescents with autism, but no one really had tried to understand how much it matters, right? So we asked two questions. One is how much time they're spending with their friends or spending time socially, and how they feel about the amount of time they're spending. So what we found is that the feelings of time about spending, whether it's too little or about right with your friends, is what matters, not the actual amount of time spent. So meaning that they can spend as little time as they want, but if they feel like that's sufficient, that's okay. Meaning that we really need to take personal feelings and needs into account when we make treatment recommendations and try to help these adults with mental health issues. That's similar for feelings of loneliness, which is also a subjective feeling of perceived state of whether they feel supported socially or not. That's what really matters in the relationship of how much time they spend socially and whether it's related to their depressive symptoms. So this highlights personal needs and feelings matter. And then we also look at employment changes. So first of all, we did see a high rate of being fired from work among our sample. And we also see that higher levels of mental health symptoms such as depression and anxiety really associated with higher likelihood of being fired. And then we also, when we follow up with adults in May 2020, we asked about their employment changes. And we found that adults reported COVID-19 related job loss or reduction, meaning they have less pay or fewer hours they work, reported higher levels of depressive symptoms than those without any changes in employment. So this highlights that employment or employment support really matter for this population. And that matters not only for feeling of productiveness and also for depression and mental health as well. So the last factor we looked at is sleep. We know that from depression studies, sleep is one of the things that being impacted by mental health, and also in return have impact on mental health. So we look at how much of the rate of sleep disturbances reported. We do see a high rate of sleep problems with shorter sleep duration, lower sleep efficiency, meaning they spend more time in bed awake than asleep, and also a delayed sleep phase, meaning sleep after 1 a.m. The lower sleep efficiency and delayed sleep phase are related with higher depressive symptoms. So this highlights that consistent and healthy sleep habits matter, and we should consider that in our supporting and treating mental health in adults with autism. So just a few highlights from our study so far. So first of all, we really need to improve the access and quality of depression services and care for our population. And then we really need to take the individual differences and individual need into consideration when we make treatment recommendations. And then it's not just about depression, it's about as a person as a whole, and it's also about the larger life context that we need to consider. And then the treatment, we can also target novel aspects of treatment to promote positive changes and to really tailor to individual needs. So this is all the findings from our study so far. I'm going to turn back over to Rebecca.
Thank you. I have to unmute myself. So yeah, so Dena's actually going to lead us in, because one of the things we really want to talk about, which I think Zheng, you already started to highlight, is this idea of care access and the impact on health and mental health. And I think we want to highlight some of these things. So Dena, I'm going to put all of this up here, for you to be able to talk through.
Sure. So many of you may be familiar with the adverse childhood experiences studies done by Folletti and team that look at co-occurring conditions that he believes is based in early childhood trauma. And the outcome are these long-term chronic healthcare issues related to things like obesity, high blood pressure, chronic digestive issues, diabetes. And it's interesting, when you look at the autism community, we experience many of those same features of these later in life chronic co-occurring illnesses. It may be a manifestation of a somatic symptom related to depression. And then again, it may just be the chronicity of repeated low-grade and high-grade trauma that autistics experience. When we look at healthcare disparities in regard to autism, we looked at the costs are these very high, very young mortality rates. Hravoski and Cassidy have done amazing research looking at this, and the average life expectancy for an autistic individual is 37 years of age, with death by water and death by heart disease and cancer, and then suicide is number 3, with camouflaging cited as one of the primary causes that leads into suicidal behavior. Delays in treatment happen very often with autistic people because they've had such traumatic experiences in accessing healthcare in general. Everything from a woman being treated for a UTI, being restrained in early adolescence possibly. And we also see in a UK study delayed access to reproductive healthcare and transgender healthcare supports. They also report executive function challenges, which kind of go right along with what Zheng was saying about access and logistics, which is an executive function problem. And then interoception can create difficulties in communicating not just the social aspects of making and engaging in an employment, but reporting what the manifestations are. So many times when autistic people are diagnosed, for example, with cancer, it's very late stage because they weren't sensing this in their body and they weren't able to meaningfully communicate. And then of course we have providers who are not equipped to translate, if you will, the more nuanced way we communicate. And then, of course, as I noted, there's a lot of increased complications based on how they present at the time it gets to the point where they just can't help themselves. For example, I had a client who had dental care issues, And the outcome of that was that she wound up with an infection that almost entered her brain by the time she finally got it treated.
Great. Dena, before I jump in and take over with the next slide, do you mind defining what interoception is for people out there who may not be familiar with the term?
Sure. So interoception is the way the body communicates its wants and needs to your mind. So simple things like being hungry or thirsty could be part of it. When it intersects with depression, or a big T trauma where you have actually dissociation out of the body, they kind of become reinforcers for one another. And so rhythmic activity has been determined to be one of the ways to re-engage the body and the mind. However, as you well know, with many autistic interventions, our first goal is to stop repetitive behaviors, which autistic people strongly feel are necessary and effective coping strategies. So there's that constant conflict going on about the purpose and the value of those behaviors.
And this is going to be important because I think some of the things that you're saying, like the emotional regulation differences and awareness and communication of like an emotional experience, as well as the body experience, awareness and ability to communicate, is so important when we're thinking about depression, because we know depression, even in typical individuals, is often very somatic. We're seeing changes in eating, we're seeing changes in sleeping, we're seeing changes in energy level and even pain. And so thinking and even mood and the ability to enjoy self. So all of these concepts I think are important, and that's why we're highlighting these differences. When we're also thinking about access to care, just one thing that I really like to point out, and that's why I'm so glad we're having this talk, is we traditionally see siloed care, that we have developmental disability served governmentally in one area where people treat just autism or work with just autistic individuals and aren't always aware is what is OCD, what is anxiety, what is depression, what is anxiety and depression, and sort of first line treatments for that. And then we have this sort of mental health basket, right? And what we are seeing, we're going to talk about a little bit more, is a lot of mental health professionals who really do know top line treatments for depression and other types of mood disorders feel less familiar and less comfortable and less knowledgeable working with autistic individuals. And I think one of the things that we're going to want to stress is when you're working with a mental health individual who really can provide good treatment for depression, we want to impress upon them that they need to put in the work. They need to understand what autism is, and that there's some really amazing resources these days out there, and then a really good and books and like things like that. And I think it's nice that within each of these organizations, there's a dedication, but pushing for that and advocating for either yourself or for your family member or loved one.
And I'm just going to jump in and say the other big problem we have is, you and I run support groups for AANE, and my women's support group, no one in the group was diagnosed before the age of 30, but they had presented to mental health facilities for depression and anxiety, which was adulterated, right? Nobody dug deeper to look for the potential developmental disability. Many incur medical maltreatment as a result of that underdiagnosis. Yes. And so if you're a therapist in the community, whether you're working with homeless people, domestic violence, whether you're working with veterans, if you don't have at least a filter for autism, you're probably going to not give them the best quality of care that they could require.
Yeah. And what we're seeing is exactly on this slide, community providers indicate that they actually hold inaccurate beliefs. So this may be is if you are an autistic individual or you are also a family member, you may need to come up with like a quick and dirty fact sheet, or you may need to have somebody who you really trust who is in that siloed care service, creating some kind of document explaining it. And I think we see this challenge for especially treatment, whether it be physical health or mental health, cut across, regardless of a person's intellectual abilities, that they're being treated differently and not really being understood their behaviors. And then this part, which really is painful to read, is they're viewed as challenging to treat. And I think it's not really that they're challenging to treat, is everything's challenging to treat when you're not knowledgeable about something. So it's really like, I think, trying to put the onus a bit more on professionals to understand more about autism, because at the end of the day, like we said, 1 in 54 kids is being diagnosed with autism, which inevitably means whatever kind of health professional you are, mental health or medical health, you will have an autistic person in your office at some point in your career. So we're banging through it, talk about how does depression look different across the lifespan. And so just one of the things that I wanted to talk about is autistic individuals are 4 times more likely than neurotypicals to experience depression over the course of their lives. And, I think we can talk about, is there something just in general that predisposes individuals to depression, or is it more that there are other factors in their lives that we're seeing, whether it be chronic trauma, isolation and loneliness, invalidation, feeling confused, the demands of masking and camouflage that then are going to prime a person for being depressed and maybe isolating some more and having lower activity levels. And we see that when youth are experiencing these mental health conditions, it's not like they age out of it. For autistic youth, they tend to have these mental health conditions, including depression, persist and worsen into adulthood. And so to me is what we also want to think about is, can we catch this as early as possible? So one of the great things is if an individual has autism and they can get a classification of autism in school and on their IEP, we then have a whole world of accommodations and services that open up to us, including mandated counseling in school, and other types of supports which can reduce the burdens, which would make depression more likely. And since we know kids aren't going to age out of this into adulthood, if anything, it's going to persist and worsen, let's take advantage of when we know we can get as many wraparound services within the school system as possible and sort of not poo-poo it, not just think this is a phase. And the real reason why is when we think about not just suffering from what depression is, but then the functional impact of depression as a standalone, but then the functional impact of depression on an autistic individual. Depression affects our independence, how we're able to execute our daily living skills, our executive functioning. Some people say the DSM-5 is actually a book all about executive dysfunction, regardless of what disorder. And it can also impact our ability to cope, our social skills, and our communication. And the reason why is these 4 bullets are all things that autistic people already find challenging. So when we're layering on major depression, we know it's going to make life even more challenging and more difficult. And so just some things to think about is whether you're a family member wondering, is my loved one depressed, or you're a professional. Autistics for depression may often present as restlessness or insomnia or sleep dysregulation. That's often a big indicator of depression and how it might look different. It's also more likely to be like physical complaints like lethargy, just feeling exhausted, overwhelmed, pain. And what we also can see is then behaviorally, we may see more aggression, more self-injury, this also mood or irritability and a weepiness. And so if you're seeing these things, while you may not think this lines up with the traditional DSM-5 presentation of depression, these are good ways to be thinking about how depression may look in autistic individuals. What we also know is, I say everything is fair game when you come to like medication for an autistic individual. You may have plateau effects or paradoxical effects. And one of the things, yes, that you may see is, a person is described an antidepressant and you'll get this paradoxical effect of aggression, irritability, and even more weepiness.
And I just want to jump in and say that a lot of those symptomologies are common with inattentive ADHD, right? And so I'm in a PhD program. I was having a lot of trouble breaking through brain fog. And I suffered with it for about 1.5 years because I thought it was depression. And I've had such a bad outcome from SSRIs for me personally. I'm not projecting that onto anyone else. So, I finally went to my doctor and he said, it sounds more like attention deficit to me because you don't have feelings of worthlessness or hopelessness. You're just flat. And I said, yeah. So there's that intersectionality there with those 2 features. And I said, I can't take stimulants because they make me agitated and irritable. And he recommended a norepinephrine acting a chemical instead, which had a much better result for me.
Yeah. And so I think, Dena, if I were to think about a practical drive home from that, is sometimes really getting really good diagnostic clarification.
Exactly.
Because there's autism, there's mood, and there may also be this impact of executive functioning or ADHD. And it's really getting that good clarification on like sort of what's going on underneath the water. Yeah, so Dena, talk us through this slide.
So I get really nervous when I, experience these protocols by which we're trying to stop necessary motor behaviors, because I think what we see and what the research shows is we see an increase in this thing called NSSIB, or non-suicidal self-injurious behavior. It's often featured within people who experience depression, challenges around emotional regulation, feeling like they don't have any control over their world and their life. And this, again, this combination of interoception and sensory issues. What we have seen, according to Maddox and Trinova, et cetera, is that it can become a slippery slope. It can slide into non-suicidal self-injurious behaviors like picking at your skin or picking at a wound on your face, or acne picking, chewing on the inside of your jaw, right? Nobody's going to die from that. But with time and a chronicity of depression and anxiety especially, what we see is people can increase in those NSSIBs, and then the intensity and the injury associated with it can evolve into, well, rather devolve into cutting behaviors. And we already know that cutting can be a slippery slope into suicidal behaviors. So it's really important to listen closely to the way people communicate their experiences. In this study, 50% of the people reported they engage in NSSIB. And women with autism were more likely to endorse this behavior than typical female college students, significantly higher. So we have to, be aware and visually like track for those kinds of behaviors, so that we can pay attention as practitioners to see if we need to be digging deeper again.
Great. Okay. So thinking about more than what are these different factors that are, and some of these things, the reason why we talk about these factors is when you're sort of gathering a history, when you're saying, what are these external things that have contributed to this experience, but also then maybe, societally we can start to change, as well as on an individual level, we can start to affect change. We wanted to talk about this. So one of the biggest things that I know when Dena and I talk offline is this idea of diagnostic trauma, of misdiagnosis, partial diagnosis, or when people finally do get a diagnosis, whether it's early on or unfortunately in 20s, 30s, 40s, 50s of autism, recommendations aren't given. It's just a label. And to me, I feel like labels aren't helpful. Labels are roadmaps. Labels are roadmaps to self-understanding and awareness, to access to treatment and accommodations, to a community, right? And if those things are missing, but what we know is the reality is there's often these things that are going on, which will lead a person to still feel confused, or years of confusion or invalidation. The other thing that we know that's particularly important when we're thinking about diagnosis is there's a lot of heterogeneity. There is a reason why there's the expression, you meet one person with autism, you meet one person with autism. And also the experience of being an autistic individual in a neurotypical world who may also have depression or other co-occurring mental health conditions is going to look very, very different across the lifespan, as there are different social demands, different executive functioning demands, also just as the body and brain change with puberty, because we know that can affect depression and anxiety. And just thinking about the impact of misdiagnosis on treatment. So I would say is when a person is walking into our office and we say, have you been in therapy before? And they say it's never worked. It may have never worked partially because they weren't being treated for what they were actually struggling with. And rather than just sort of poo-poo that statement, is digging a little deeper and thinking about it. What we also know realistically is there are real disparities on who gets diagnosed and why. There's gender disparities, sexual identity, and racial and cultural disparities. And we could probably do an entire talk on those things, but unfortunately, we're just including it as a bullet right now, but we're happy to give some resources on that. Last but not least, I just want to bring up this idea of diagnosis diagnostic overshadowing. That since we do know that there are both medical and mental health conditions are often co-occurring with autism at higher rates than neurotypicals, like Dena said, it could be ADHD, it could be depression, it could be OCD. A lot of times things look similar, right? And so people will say, oh, that's just OCD, and sort of dismiss some not red flags, but red flags of missing a diagnosis to autism, and then missing co-occurring trauma. What we also know is, yeah, and I'll leave it at that just for time's sake. Sure. Dena, do you want to talk about this slide, like some other factors?
Back to the other one, I just want to say too, we tend to, and the DSM promotes this idea that functional capacity is a constant, right? And so I always say, I have low support needs unless I fly Southwest, because I have so much trouble getting my accommodations. I can flip a switch, and between PTSD from repeated failures there, compounded with somebody just not really listening and being supportive, I can get pretty, the person said, you don't look autistic to me. And I said, I'm about to, right? So we need to realize that the outward expression of autism can ebb and flow depending on the experience, the environment, whatever's happening. And it's interesting that in Shating's study, one of the studies she posted, she talked about financial issues being the #1 challenge for autistic adults in terms of depression. It's hard to imagine why that's not the case when we are automatically $2,000 a year below the federal poverty line by living on SSI. Now, if you live in West Virginia, where my son went to college, you can pay your rent and have cable TV on that. If you live in New York, you're on the streets on that amount of money. And the systems are completely overcome right now with COVID long haulers, early retirees, people who are trying to navigate these support systems that never had them before. So it's really important that we start to advocate in terms of macro systemic policy change to make sure that autistic people and other disabled people have a living wage that they can survive on, and that it be regionally based, not based exclusively on this national rate. And this whole idea of being unemployed and underemployed versus being employed with ongoing job supports is a critically needed area of support for autistic individuals.
Yeah. So Dena, we're running low on time, so I'm
Go
just going
ahead.
to say one quick thing and forward us along. I think if we're thinking practically again about this, what this means is start as early as possible. Like if it makes sense for your child to get vocab supports while they're still in school, push for that. Make sure also as therapists, we're saying like, we can't really be talking about behavioral activation if a person is not sure how they're going to pay their bills. And then also actually thinking about what are the statewide systems where we can access financial supports and other types of supports, and getting into that process early on if you're a caregiver, and maybe even really sitting down with a lawyer and thinking about, until society really catches up to the need, what do we want to do to practically care for our loved one? Yeah. The other things that I would just sort of say to think about is this idea of bullying, that when we talk to most autistic adults, they can talk about bullying and isolation as large parts of their childhood versus this idea of radical inclusion. And I would just say for us as just people to start to practice this idea of radical inclusion, because we know loneliness is a strong predictor of depression. We also do want to be looking at family histories, because if people are still living with their family members and their own family members are struggling from mood disorders and depression, or maybe are undiagnosed autistic individuals, that can impact the people that we're working with and our loved ones. And then the last part is more autistic people identify as gender fluid or gender expansive. And we also see with amongst individuals who consider themselves gender fluid, they have higher rates of autism. And I think this adds an extra layer of health concerns, mental health concerns, but also unfortunately areas that are ripe for invalidation and dismissal of a person's actual experience that they're trying to express, and to be thinking a bit more about that. the last things that I think we'll talk on, and then we'll move to Q&A, is this idea of sleep and movement, how depression can often be thought of as a sleep disorder. And as Ting mentioned, like we're definitely seeing different circadian rhythms. We're also noticing more social isolation from maybe movement and physical activity challenges, as well as sensory sensitivities. If the world feels uncomfortable to us or overwhelming sensory wise, we're more likely to isolate. We're less likely to have distress tolerance and coping. And again, we're not going to be sort of connected and moving our bodies in the way that we know are good buffers against depression. And then we have our interoceptive and emotional dysregulation, as well as one of the strengths that an autistic individual can have is sort of hyper focus on things, which sometimes is also thought about as repetitive thinking and isn't necessarily a bad thing. But what we know is that if this is sort of the way that the brain processes information for a lot of autistic friends, is that this could lead to a vulnerability for rumination. Rumination is when we have repetitive behaviors and intensely focused thoughts on negative things, right? And so this is also really going to complicate the experience of depression. So thinking about that, but it's sort of pushing a boulder on the hill, up a hill, if we're just going to say stop ruminating without really addressing that this is sort of way the brain processes information in this more sort of repetitive, fixated way. Dena, do you want to add anything to this?
No, but I do want to talk about camouflaging really quick.
Yeah.
So I just, I have a very different take on camouflaging. I think we've tried to make this a uniquely autistic experience when it clearly is not. Who you are with your new job interview scenario is not who you are on your girls' night out. So, all autistic people, just like all other human beings, engage in social camouflage. What I believe and what I experience differently is I believe what we're really looking at is an undue burden to execute this normal behavior, right? So for autistic individuals, the executive function burden around social camouflaging is just decimating. We have to do context reading. We have to try to listen to the primary speaker. We're trying to scan the environment for sensory issues. We're trying to rehearse a script in our head for the next thing we want to say. And then we have to try to deliver it in a way that's got time and rhythm to it. And I think it's that piece. I think it's the executive function, the sensory, possibly prior social trauma that combines together to make masking unduly burdensome for autistic people. And I do think that that cognitive fatigue drains from our rain barrel of productivity such that we do become very frustrated and overwhelmed and exhausted. And that, again, that heavy labor and constant demand to do so can be really decimating to the human spirit and the human psyche. I was born on the far end of the spectrum. I'm not shy, but I'm an extrovert on steroids. So there's no containing this. I'm out in every environment I'm in. I disclose up front. I solicit active feedback from all of my peers so that I can continue to have positive reinforcement about the things that are working well for me and constructive feedback, not criticism, on areas where I can grow, right? When people don't have access to those resources, they don't have the confidence in their competence to be able to participate in a social setting, it can lead to these feelings of isolation and abandonment.
Yeah, because Dena, I was going to add in, I also think part of what's different with camouflage and masking for an autistic experience is the pervasiveness of it across environments, right? So I can go in and I'm typically my authentic self, except for when I'm going into a conference, when I'm going in on a job interview. But for a lot of autistic individuals, it's this inability to feel comfortable or accepted to be your authentic self, like across environments. That addition to this can feel so taxing, which is why sometimes when I meet family members and I talk about this concept, parents go, that's great. That's great that my child is like getting it and understands the social rules and is masking and social camouflage. And I actually have to point out and break down, no, like I want your child to have a choice in the same way, Dena, you have a choice of when to turn it on, but I don't want your child to ever get the message that their authentic self is not worthwhile, and also that they have to go through this exhausting process, and that they're alone in this, and helping understand that.
Research is showing that camouflaging causes people to lose touch with their identity altogether. The lines between who they authentically are and that awareness of when they're turning it on and turning it off starts to get vaporized over time. Yeah.
Great. So we're just going to leave this up here. We've really talked about this. We need better screening tools for that diagnostic clarification, for professionals to get trained and close that knowledge gap, making sure we're engaging autistic individuals and talking about this. Definitely thanks to Zheng et al. Researching tailored interventions so that we can use them and learning more. And this idea, I would fast forward to this idea of creating more and more community and inclusion to this. So we're a few minutes behind, but I'm still going to give myself a pat on the back because I think we gave a lot of good information, and we will now pop over to questions. We've been trying to answer some of the questions like in the chat, but we also want to dive into some of this stuff now. So I guess one of the questions that I would say is for people who have been seeing sort of an escalation for autistic individuals or an autistic loved one with depressive symptoms and feeling like we're somewhat under-resourced, what is like sort of the first thing a family member could do to sort of help their loved one get out of depression or more independent living skills? And I'll give Zheng and Dena an opportunity, and then I can give my thoughts. Yeah.
Go ahead, Zheng.
Yeah, okay. I think one of the things also through our research we want to push for is really trying to think from an earlier developmental standpoint, right? Like, I think if we wait until adulthood, a lot of the behavioral patterns and experiences and challenges have been in place for a long time. But if we can intervene or even prevent some of the more negative impact of depression or mental health to kick in, I think we may have better success. I think one of the findings we have from our longitudinal checking of depressive symptoms is that it's pretty stable, at least in our sample. And also from the lens of treatment that we're seeing, it feels like it really requires prolonged treatment when it comes to adulthood. So if we can do something earlier and try to intervene and prevent more negative consequences to happen before it happens, I think we may have better success. Of course, that will require us to do more research and start early with like a lessonhood or even earlier in the younger childhood to teach about emotional regulation, awareness, and social emotional skills. So
I can just report, you know, my son and I are both diagnosed. He was diagnosed at 3. He's never known a day where getting help was not okay. He's never known a day without the word autism to help explain himself to himself as well as to others. And he's 32 years old this month and a healthy, well-adjusted young man without depression and anxiety. That's very dramatically different from people like myself who wait until they're 40 to get diagnosed, right? And it's interesting, now I'm getting to watch my daughter raise my grandson with a neurodiverse parenting style, right? Because it's the only parenting style she's ever observed. And I keep thinking, why aren't we raising all kids in a way that suggests that they need to be more sensitive and we can't assume anything, we have to teach everything, and we have to teach them how to make decisions and how to make choices. You know, I mean, I think that's the core of this. It's not social skills training and teaching autistic people that be more normal. It's teaching autistic people how to be happy with themselves as they are, and then to provide them the language they need to translate this into other environments. And when we do social skills training, we need to do it for the typical peers as well, right? Like we taught everybody my son was exposed to about autism, and he had an extremely successful school career. not because we wanted him to change, but because we changed the environment around him.
Yeah.
Yeah.
And so I would say, last but not least, practically for this parents out there who's seeing their child suffering and they sort of feel like, what do I do? I think the first thing is really sending the message to your child, like, I want to understand you better. I want to make sure you understand yourself. And I unconditionally love you, because I think a lot of times we can experience frustration and anger at our children, and they really feel that and then are angry back, and sort of breaking through that. But then what we do know is one of the first line treatments for depression, regardless of neurodiverse or typical, is something called behavioral activation, getting moving, getting engaged. That when you're feeling depressed and you're feeling low energy and you're feeling low mood, the last thing you want to do is get out of bed and get moving and do an activity. But paradoxically, it's the best thing for you. So that would be, I would say, the targeted thing. One time a day, getting up, like, let's go do something. Let's go watch a TV show together. Let's go play a video game together. Let's go cook a meal together. Let's go to McDonald's and just take a quick drive, or let's take a quick walk. Things that also feel doable, but sort of collaborative, engaging, and that will also feel positive and rewarding to your child. That's really finding out what's going to motivate them to get out. But I would also say sleep regulation is going to be the hugest thing. If we know that we're staying up really late at night, sleeping, and also taking naps, that is going to be a mood killer. And so one of the things that I would say is it's hard when a person's staying up late at night and their whole circadian rhythm is thrown off to like shift a person back to the morning. But you can maybe have a conversation that's saying, let's ban naps. Let's ban naps in our house. And when you're feeling the urge to nap, that's when we're going to go out and do this fun thing together. Or that's when we're just going to sort of sit on the couch and watch TV, because by banning naps, you're really making a difference in that depression.
And I want to point out that often we have adults whose circadian rhythm are not leveled off.
Yeah.
And then we put them in a job.
Yeah.
And they're sleep deprived the whole first 2 weeks of training, and then they crash and burn in a month, right?
Yeah.
Right. Yeah.
Yeah.
I also want to piggyback on Rebecca's point on behavior activation too. I think that's one of the, at least from what I read in the literature, is one of the treatment that actually works across the functioning levels, like nonverbal and the verbal individuals can benefit from behavior activation to get up to doing things. And also, I think the other piece is the fostering the positive experience and positive mood through this activation, and doing things together is also very important. And one of the things we analyze from our data too is like, we asked the autistic adults what made them happy throughout the past week. And a lot of the things identified is very similar to everybody. So there's like no like real, I guess not say no real difference, but like it's very common things we all enjoy. So I think to foster that together as a family, or to intentionally provide that to our individuals on the spectrum, is also very important to have the positive experience. And that will only, I think, positively have a feedback loop to cultivate more.
No, I think that's great about your point about across verbal and intellectual abilities is behavioral activation works. So let's just get moving. And also so many times we use like sort of control strategies or manipulation strategies on our autistic population, and thinking about, well, like getting moving and like eating something fun, doing something fun, like this is a worthwhile intervention, and it's definitely not a control strategy. I want to get to two more questions, like maybe we can stick a touch after one, but this one question is, somebody's saying, my clinical diagnosis is GAD, but I've been informally told by a psychologist I likely have autism, like the other people in my family, and that I should see someone who specializes in that to deal with my anxiety that medications have not been able to help me with. I ruminate and have stress from uncertainty and lack of control. When I tell my HMO, they just refer me back to mental health providers for anxiety. I do not know how to be assessed or find a specialist and afford it. How do I ask for the right thing? So I'm going to give two plugs. There is a wonderful book called Living Well on the Spectrum. It is a workbook written for autistic individuals that as much as I'd like to say go to a provider, I actually think as you're sort of in this frustrating cycle, you can read the book. There's also Dena facilitates some wonderful support groups with an organization called AANE. And so that might also be a place to go to. Dena, do you have other ideas on terms of accessing individuals in the know-how or diagnosis?
You know, there is a code switching that goes on when you're dealing with insurance. And so you have to use the magic words. You have to say the word autism with your provider. You can't just mention all your symptoms. You know, like for many years, I was underdiagnosed because I have a history of sexual abuse in my childhood. So everything that was wrong with me was about abuse. Nobody looked to see that my mother was also autistic and she married a predator because of her vulnerabilities, right? So, you know, I would use the word autism with your HMO. I would also recommend the book Spectrum Women. It's a really great resource for autistic women who are examining this possibility. And, you know, and I would try to find like a Facebook group in your region of autistic women just by searching to see if you can get a local recommendation of someone that other
I don't know if we know if
often,
this is a woman or a man, but still, yeah.
I'm sorry, I apologize.
Yeah.
But someone who's got success in diagnosing autistic adults who've learned and been groomed and been socialized to not present, right? We need somebody that's going to tease out the nuances of the autism. So that's it.
Yeah, so the books that we mentioned, yeah. Oh, you go, Dena.
I'm sorry, I don't know Valerie's book.
Valerie's book is called, it's Valerie Gauss is the author, and it's Living Well on the Spectrum. And then
my book is Spectrum Women Walking to the Beat of Autism.
It's got a beautiful cover also. Yeah, great. So I think the last one maybe we can touch on is people are asking, I see a couple different questions about what's the difference between perseveration and rumination. I can give my armchair answer is rumination is really when we are stuck in a loop of examining depressive thoughts and depressive mood and really staying on that. So the focus is on sort of this depressive aspect of it. And what we can almost see is even though it doesn't feel good, it almost gives sort of like a functional quality or an illusion that I'm doing something, right? I'm feeling low mood. I'm feeling depressed. I'm feeling concerned and worried about something that happened in the past or something that's upcoming or how I feel about myself. And by sort of concentrating my focus on these negative things and staying in that zone, it creates the illusion that I'm doing something a little functional. Perseveration, I would say, isn't necessarily on anything negative. It may be, but not necessarily. And I think the functional quality is sometimes there really is a positive functional quality to perseveration and to sticking on a topic. You know, I've been sort of perseverating on like our time schedule throughout this. And even though I wasn't perfect, there was a functional quality to that. So yes, and Dena and Shating, I don't know if you want to give your last thoughts.
From an autistic point of view, just from my personal experience and observing my son, the difference is joy. Perseveration quite often is a really happy place to be. My Thomas the Train is autism. And, you know, I haven't read a nonfiction book that wasn't about autism in 15 years, partially because I'm a PhD student, but it's my STEM, you know, my happy place. My son's is World War II, anything about World War II, Disney princesses, and, you know, Sailor Moon, you know, he has his things. And, you know, he's perseverating on the fact that he wants to work at a single museum. And we can't break him out of that to work somewhere else because this is his childhood home and what inspired all of his goals throughout his life. So that's where you go from perseveration that's happy making to happy perseveration that leads to dysfunction. Like, it's like, yeah, maybe we need to just take a job at a pet shop for a while until we get something else. And we're not having good luck, but yet we're a family that believes in self-determination. So we're just, you know, going to ride it out until the museum breaks down and hires it for a few hours a week. So, you know.
Yeah, I think you two covered it all, but I think one of the things I would like to think of perseveration that's different from rumination is I think it's sometimes soothing for some of the individuals we know on the spectrum to be perseverating on a topic of interest, right? But rumination is a lot of times have a negative feedback loop where you kind of get stuck in a place where it's hard to break the cycle of thinking something different, and the thoughts of rumination is impacting your mood negatively. So that's how I want to kind of think about the two that's different. Yeah.
And I know we're going to close with our out. People were asking, like, what do you do with rumination? So I think the idea is starting to really reinforce the concept that thoughts are just thoughts and feelings are just feelings that we can sit with and that don't necessarily have to be acted on or controlled. Because we know the more we try to control things, the more actually it creeps up more. And I think really dialing into, at least with, I would say, individuals who are more verbal, is their idea of values. Like, what kind of person do they want to be? What kind of life do they want to live? And how is sort of giving so much attention to these negative thoughts getting in the way of those values and valued action? And what's one small thing that they can do that's more in the service of their values, even when their brain and body are sort of screaming at them, pay attention to these negative thoughts? And that might be doing something kind for someone else. That might be doing a mastery activity along those lines.
And I would say too, for the parents who have very young kids, make the world as predictable as you can early on.
Yes.
If you unfortunately, like I did, didn't get that message early on, be accountable to your kids for what you didn't know. It's very, very important to reestablish a sense of normalcy and predictability in their lives. And if you have inadvertently not provided structure and pushed them beyond their capacities in the past, you now have to rebuild that relationship to reestablish trust. And so acknowledging what you didn't know, speaking your truth about that, being accountable about that, and then doing everything you can to respect their need for predictability can go a very long way in terms of making life better. And it can be as simple as, my husband's like, Patrick keeps asking me when I'm working, because my husband's schedule rotates. I said, buy a calendar. Like, just put a calendar on the wall. And he goes, he stopped asking those questions. I go, and now my son's reminding my husband of his appointments to the dentist. So it can be a win-win for everybody.
Awesome. Well, thank you, Zheng and Dena. Zheng, it was nice to meet you.
Thanks,
and
everybody.
do this.
Yeah,
Dena, it was
nice to
nice.
meet you.
And Beverly, if you want to take us out, that would be awesome.
That's all the time we have for today's webinar. Thank you so much. It was so fascinating. Rebecca, Zheng, and Dena, amazing presentation.